In 2025, the Fire and Rescue Department will issue Scalpel Crite kits to all frontline ALS units. This device is designed to provide clinicians with the appropriate equipment in an organized fashion to facilitate a high-stress, low-frequency medical procedure. In 2024, the EMS Equipment Committee began a systematic review of cricothyrotomies performed in the field. During chart review and during interviews with providers, many challenges became a common thread. Some of the challenges included kinked ET tubes due to the significant amount of tube outside the body, right mainstem intubations, or too deep intubations, and not having a simple way to secure the tube. Previous training included using tape, IV tubing, or even an upside-down Thomas tube holder. It was clear that providers needed procedure-specific equipment to ensure success on these high-risk, low-frequency events. The committee reviewed several brands and manufacturers before ultimately settling on the Scalpel Crite kit for the following reasons. The kit is organized, fits within existing protocol, and has an extended shelf life. Many kits had an application technique that was different than current practice. The challenges of training all providers and all ALS providers having hands-on time on an entirely new system would delay implementation and be challenging to fit in the current environment along with other departmental expectations and challenges. The Scalpel Crite kit has a 5-year shelf life and includes specific equipment for this procedure. The equipment is also interchangeable with current FRD equipment in the event a backup item is required on a call. For example, if the bougie was to fall on the ground, a standard FRD bougie could work. Or if a cuff failure occurs on an ET tube, it could be replaced with a standard Fire and Rescue Department cuff tube. All items are laid out in pockets on a sterile sheet. Providers work from left to right to perform the procedure, making it easy for an assistant to hand items to the primary clinician. Included in the kit is a number 10 scalpel, a 14 French bougie, a 6.0 ID tube with cuff, extension tubing, a 10 cc syringe, and a neck tape. We will now review each of these items in further depth.
The Scalpel Crite kit contains a number 10 scalpel. Previous training used a number 11 scalpel, but both devices operate in a similar manner.
The bougie contained is a 14 French 40 centimeter bougie. There is centimeter marks on the side of the bougie. During insertion, it is recommended providers insert the bougie 10 to 15 centimeters and should feel the tracheal rings during insertion. The tube is a procedure-specific 6.0 cuff tube. It has a rounded tip to prevent trauma in the trachea during insertion and is bent to ensure smooth passage into the trachea. There is also an adjustable flange to prevent the tube from being placed too deep and for securing the tube. Also included is corrugated extension tubing. This prevents items like the BVM and capnography from stacking vertically on the trachea. This extension also swivels and allows for suctioning up to a 16 French catheter. Once in place, the tube can be secured by a soft necktie. The necktie uses hook and loop to secure the tube in place. We will now begin a review of the existing protocol. The indications for a cricothyrotomy include patients that are over 8 years old that cannot be oxygenated or ventilated, and all other basic and advanced airway techniques have failed. This could be due to an obstruction like angioedema or burns or extensive facial or neck trauma. Ensure the use of appropriate PPE to include a face shield when performing this procedure. Next, prepare the patient for the procedure. Place the patient in a supine position. Trauma patients will likely require full spinal motion restriction. Remove a cervical collar and manually stabilize the C-spine during and after the procedure. A folded or rolled towel under the neck may assist with stabilization. Additional considerations include physical and chemical restraint and also provider positioning for this procedure. Providers should plan to restrain the upper extremities to prevent the patient from interfering with the procedure or displacing the airway. Additionally, after the procedure is complete, consider midazolam 5 milligrams IV or IO slow bolus as required. When positioning for the procedure, the provider should stay on the side of the patient that is their dominant side. For example, a right-handed provider should typically stay on the right-handed side of the patient. Next, we're going to locate our anatomical landmarks. The cricothyroid membrane can be located by palpating the sternal notch and then the trachea. Carefully move up and down until a perpendicular ridge is felt. This is the cricoid. The point prominence just above is the thyroid cartilage, which is the larynx or Adam's apple. The space between these two prominences is the cricothyroid membrane. It is noted by a small depression. There'll be another depression superior to this, which is the thyrohyoid space. This is not the desired location. The next step is to place the airway. Begin by cleansing the site. Then, grasp the larynx with your thumb and middle finger of your non-dominant hand and locate the cricothyroid membrane with your index finger. Then, make a vertical incision approximately 3 centimeters long, followed by blunt dissection or spreading of the skin using your finger to the level of the cricothyroid cartilage and membrane. Confirm your landmarks and desired location, then proceed with a horizontal plunge cut through the cricothyroid membrane. Use caution not to insert too deep and risk puncture of the posterior trachea. Use your finger to secure the opening and hold a place. Bluntly enlarge the opening with your finger. Use caution not to have your finger and the scalpel in the same area at the same time. Use suction or gauze sponges to help with visualization and to maintain the airway. While maintaining the opening with a finger, use your other hand to take the bougie with the bent tip pointed towards the feet and introduce it into the trachea and downward towards the patient's feet. Feel for tracheal ring clicks and then stop. You should encounter the carina within 12 centimeters of insertion, much more shallow than a regular intubation. Keep one hand on the bougie to avoid displacing it. Advance the 6-0 endotracheal tube over the bougie and through the incision site. Some slight pressure may be necessary. Once the balloon is fully through the skin, it is deep enough to inflate. Gently withdraw the bougie and begin to BVM ventilations. Confirm placement using capnography and standard clinical methods. After the tube is placed, secure the airway and take all necessary steps to avoid displacement. Ventilate the patient and apply all monitoring equipment. Consider additional sedation as required.
This is the final video for the Scalpel Crite kit, putting it all together. The first thing we're going to do is identify that this is the procedure the patient needs. Following that, we're going to cleanse the site with alcohol or a cleaning agent, and we're going to locate our landmarks. We're going to feel upward for the cricothyroid membrane as seen in the previous video. We're then going to utilize our middle finger and thumb to hold the skin taut and locate our landmark with our index finger. We're then going to work left to right in our Scalpel Crite kit. We're going to get our scalpel out, and then we're going to clear our hand out of here, and we're going to make a vertical incision. I'm going to show you those on this mannequin here. Again, we've located our notch. I'm holding the skin taut, and I'm going to make a vertical incision and spread with my fingers. Once I have an incision and I have my landmarking, I'm going to make a horizontal plunge cut in that area, remove the scalpel, and utilize a finger to maintain control of that area. I'm going to dispose of the scalpel in a sharps container. I'm then going to take my bougie with the coude tip downward, and I'm going to press that into the trachea 10 to 15 centimeters. I'm going to hold control of that. I'm going to take my tube with the balloon side down, thread it over the bougie, and I'm going to pass it into the trachea. As soon as the balloon disappears from view, that should be deep enough. We're going to remove the bougie and we're going to inflate the cuff. Okay, we're going to add our extension and our BVM. We would attach our BVM with oxygen here. We're going to ventilate the patient and confirm that we have the correct placement and that we have bilateral lung sounds. Be extra cautious that we don't have a right main stem and that we have bilateral lung sounds. From there, we can adjust the collar against the patient's skin and then tighten it. And then we would utilize the Velcro strap by coming through the eye holes on either side back to itself. And then around the patient's neck. Through the eye hole and back on itself. From there, we're fully secured. We're going to ventilate the patient and be prepared to provide any type of sedation or analgesia related to better oxygenation and having an advanced airway in place.
The Scalpel Crite kit will be deployed to all frontline ALS units, including AFR units. It will be kept loose in the main area of the EMS bag next to the intubation module. There will be PS Tracks updates to follow. If utilized, request a new pack via the EMS online ordering through EMS Logistics. Reminder that all cricothyrotomies require Deputy Chief of EMS and OMD notification via the EMS officer within 24 hours.